Professor Sharma. It is indeed an honor and a pleasure to be sharing my experience with Toric IOLs today. Uh, the talks so far have been excellent, and I'm still learning and learning a lot. Some of the points may be repetitive. I'll try to exclude those points. In order to have excellent results, we either need to be, very lucky surgeons as far as toric practice is concerned, or we have to be really meticulous clinicians. Because primarily in a toric practice, there are so many errors, so many sources of errors, right from your measurements to nomograms to head tilt, reference marking, axis marking, IOL rotation. I like to call all these sources as, as stacks. And if you are a fortunate surgeon, your stacks will, you know, balance each other out. If you have made errors in the keratometry and the patient has tilted his head to the other side, these errors balance each other out and you may get a reasonably good result. But more often than not, these will stack unequally. And the biggest stacks are your measurements, the head tilt error, and the calculators. If these stack all on one side, we will have a huge residual astigmatism. I'll touch upon the source of errors very briefly because in the interest of time. But three questions that we need to really address is how much do we treat? What are thresholds for treating astigmatism? What do we aim for post-operatively? And do I flip an axis or let it be? To have excellent results as far as the advent of premium IOLs, especially the multifocal IOLs and the trifocals, which will result in some loss of contrast. If this gets compounded by residual astigmatism, then we are going to have a patient who will have visually or not a very satisfactory experience. So we need to target and get as close to zero as possible and be below 0.5 diopters post-operatively. On the Barrett suit, I personally aim for 0.25 with the rule, and hence do not hesitate to flip the axis towards WTR, avoid any residual ATR. So my current thresholds for an post-op estimated residual astigmatism, if the ATR is more than 0.3 diopters or the WTR is more than 0.75 diopters, I'll go ahead and use a toric IOL. In this study, about 75% of the patients who had residual cylinder had an axis which was 5 degrees away from what the intended axis was. And we all know that the difference between a manual marking and a macular system is negligible, about 3 degrees. So primarily, most of our errors occur primarily because we have erred in the calculation and the measurement rather than the IOL placement. The cornea is a beautiful tissue and extremely difficult to measure. And that is why we need so many devices to measure the cornea. The autoclave, the optical biometers, the topographer, and yet the net K is elusive. Primarily because there are so many devices and all of them have so many inter-device variability. There are intra-device variability in some of the devices. And to compound all of that, we have operator variability also. As a result, at the end of the day, we are bombarded with so many data points, so many numbers that it becomes difficult to choose which to use. What I personally do is avoid looking at the printout. You have to go to the machine and see the raw data points in all your patients. See all the scans, see all the measurements, see the quality of the Myers, also touch upon whether the pupil was dilated or undilated. This patient, if you see the scan here, these dots, these are the things that you should really need to look at. If the numbers all match, look at the keratometric dots. If these are sharp and very focused, then you have a good scan and you can use this scan for your calculations. Another patient, if you see these dots here, these are slightly smudged. And this patient we have to postpone. If you go back and look at the patient, the ocular surface was not very good. So you treat the patient. This patient came back again after 3 weeks after a full treatment with doxy, hot compresses, topical steroids, and the scan quality improved. We looked back at the measurements and there was a 0.5 diopter change in the IOL power. Once we have a good scan, now we don't need the keratometry. We need the total keratometry. Exactly what is the total net keratometry of the patient. So we have two options. Either we use the predicted PCA or we measure the posterior corneal astigmatism. The Barrett-Toric calculator, as all the speakers have said, is the most beautiful piece of work. It calculates the IOL power beautifully in most patients. But we have to use the measured PCA, and we can use either sham plug devices. However, these sham plug devices like the Pentacam or the series have high inter-device variability, where hardly any of your readings will match each other. There'll be so much variability. And the IOL 700 TK, which is much more reliable. In these studies which have been done in non-complex size, measuring the PCA or estimating it with the Barrett formula will give you equivalent results. So whether we use the TK or the K, results are going to be similar. But in eyes which are different, which have had a prior refractive surgery, RK, or a surface treatment, or even in those which are having pterigem or corneal scars, the PCA will give us superior results. This is how we go about using the PCA. By default, the measured PCA will not be there. The predicted PCA is there in your Barrett calculator. If you want to use the measured PCA, click on that, another window opens, you feed in your data from the Pentacam, and it gives you the nested astigmatism. We just rush through a few examples. Here is a patient with 2 diopter of ATR. We select one scan, which is the mean of all the scans. Don't take the mean, but you pick up one particular scan, and that is the data that we use. We punch in our data into the Barrett TK Toric calculator. It shows us that we need to correct about 2.5 diopters on the IOL plane. But it will give me a residual of about 0.2 against the rule. I would want to flip this to about 0.6, so I go and select 3 for this patient. Although the Barrett Toric suggesting 2.5, we intentionally will correct 3. If you compare this with the K, also it is suggesting, the Barrett is suggesting 2.5 here, but we are using 3, and we have a good post-op result with a small 0.25 with the rule correction. Similarly, here patient has 1 diopter of against the rule astigmatism. The Barrett Toric TK is suggesting to use 1.5. We use a 2, and with a slight flip of the axis. The Barrett K Toric calculator also is suggesting 1.5, but we go ahead with 2, and the post-op refraction is plano. This is a case of with the rule astigmatism with 2 diopters with the rule astigmatism. The Barrett TK Toric calculator is suggesting 2.5, but I want to leave behind some with the rule, so I selected +2. If I check the K was more reliable. The Barrett Toric K calculator, here it is suggesting 2. So we went ahead with 2, and because this patient was myopic, 10.5, we aim for a -0.5, and we have a -0.5 diopters here. This is a patient with oblique astigmatism. The patient had a corneal scar, but the keratometry readings were very reliable. All the machine gave the oblique similar axis and about 3 diopter of astigmatism. The Barrett TK was suggesting a 3.5. We wanted to just debug the astigmatism, we used a 3 here. The Barrett K, however, was suggesting 4.5. So Barrett K, as you know, is a predicted PCA is being used by that Barrett Toric calculator, whereas the Barrett TK was the measured one. So where the measured here was more reliable, and we used a 3 here, and we got a 0.5 residual astigmatism. Coming to marking patient, we are all very conversant with our manual marking, and some of us are using the image-guided markerless system like the Varion and the Callisto. My personal experience is only with the Callisto. The main source of error in marking is the head tilt, which is totally operator dependent and causes not only the error in your markings, but also the pre-op measurements in the axis. This is an old slide which we use for training of our operators. The patient is put on auto ref. 5 readings are taken for both eyes with the patient adjusting his head on his own. And then we readjust and take 5 more readings with the eyes properly aligned. And there is a 10 diopter, 10 degrees difference in the 2 readings. The 3-step technique, all of us are very conversant with, of manual marking. We had done a study at our center which got published last year. This is a 4-point marking system, and a fourth step is introduced. In here, instead of just 2 marking in the horizontal axis, we would put 4 marks, and then we put the patient. These are the marks that we put on the slit lamp. We note down which axis we have put these marks at. Then we put the patient on the topographer on the Sirius machine and use the digital goniometer and mark out where these marks are. Once we know the mark, we just manually write down on the patient's notes, and these notes go to the OR. So these are the 4 marks that we see under the microscope. We know one of these marks is at 43, the other is at 180. Now this helps, these marks helps us to center the gauge correctly. Initially, I would always place the gauge on the cornea, just aligning the 180 degrees. But here we know that this mark is at 43. However, if you center the gauge just on the cornea, this mark is at 30 degrees. So to align it at 43, I have to shift it nasally. When I do that, my 90 degrees matches with the first Purkinje image, and the oblique comes to it. So there has to be always remember that there has to be a nasal scleral show while putting the gauge. This will avoid less errors in oblique axis. It's a very crucial step for oblique axis placement of the lens. The digital markerless systems are also not without any errors. We have registration errors, loss of registration intraoperatively because of chemosis. There are parallax issues. Sometimes one axis, one of the marks of the IOL will match with the Z line, the other don't. The head tilt errors don't get eliminated unless your measuring device is the same as your imaging device. And there is no way of objective way of confirming whether the patient was fixating in your reference image except in the IOLmaster 700. These are the initial cases when we are using the Callisto ways to mark the patient also. This is faulty registration where the 180 degrees is just not matching with the 180 that we marked on the slit lamp. After re-registering the patient, the same patient, it comes on. These are parallax issues. These parallax issues can be avoided if you use only the coaxial illumination. The minute the side illumination comes, their parallax issues come into play. How do we select the reference image? If you want to avoid all the head tilt errors which are there in your reference image, you have to use the same for your final calculation. So whichever scan that you use for your final calculations, the same scan has to be, the same reference image has to be used for your registration. Also check for your foveal fixation and also the iris barycenter readings. Few things I learned about the Callisto Eye is that the reference image is a subject fixated, coaxially sighted. So hence, even my registration should be coaxial illumination with the patient fixating. So I shut off my side illumination and only during the coaxial illumination ask the patient to look at the center 2 lights. And one of the light has a small notch in which the camera is there. If the patient is able to fixate, I will get good registration. Avoid tilting the microscope head. This is a common thing we do if you want more working space, but this should be avoided if you're using the Callisto Eye. So I just use the coaxial illumination, ask the patient to fixate in the center. And once I have good registration, I go ahead and mark my points. So once the manual marks are there, I can shut off the Callisto. So in case I lose the registration intraoperatively because of chemosis, no worries, I don't have to re-register the patient. I can just go ahead and finish my case. Once the surgery is over, I again put on the ZLN and recheck my markings again. Despite a good surgery, you will still land up with misalignment. And we know if it is more than 10 degrees, we are going to have a substantial undercorrection. So what do I do in such cases is on day 1, we do the auto-refraction of the patient. If the visual acuity is less and there are significant astigmatism on the auto-ref, on day 4, we dilate the patient, do his refraction, do the IOLmaster again, and just talk to the patient, just give him some idea about the residual astigmatism. On day 10, repeat the refraction again, do the IOLmaster again, dilate, find out the current IOL axis, and then calculate where the lens has to be rotated, depending on using either the astigmatifix.com or the Barrett RX. Between day 11 and 14, we realign. We everyone is conversant with these two these two calculators, how to calculate and realign the lens. So I will not discuss that. But there are two variables that we need to understand in using the astigmatismfix.com. One is your manifest diffraction. Now this has to be absolutely accurate, which is so in most of the cases. The other variable is your current axis of toric lens. Now I struggle sometimes with knowing whether it is 75 or 80 if the lens is at 75, 80. 5 degrees is an error which will always creep in when we are measuring the current IOL axis on a slit lamp, especially if the patient has slightly tilted his head. So just give you an example. This is a patient in which the axis was at 75, the current axis, and the calculator told us to rotate the lens by 68 degrees. Now, if instead of 75, I punch in 80, it tells me to rotate by 78. So my error gets doubled. So instead of 5 degrees, I'll end up with a 10-degree error in the final orientation. So which amounts to about 30% of the astigmatism loss. So to come around these errors, what one can do is on the day of surgery, when you have to realign the patient, you measure your axis, the current axis, also do your refraction, put in all the numbers and find out how much the lens has to be rotated on the calculator. Along with that, you do the IOL master 700 of the patient and take his reference image. Also find out where the steep axis is on the TK, not on the K. Once you know what the steep axis on the TK is, that is the steep axis on the cornea. You compare it with the pre-op also. If it is matching, and if your astigmatism fix is also suggesting similar axis force on it, then we are sure. But if not, then in the OR, once the Callisto registration is done, you find out the current axis of the lens in 1 degree steps you can find out. And then determine the current axis of the IOL on the Callisto and compare it with the axis which you measured on the slit lamp. Reconfirm the alignment, and finally you can align your lens on the steep axis or on the freshly calculated axis. To summarize, in toric IOLs, we need to eliminate few of the stacks, few of the errors, which we can do with the current, which we can do only with technology. And there are some stacks which are the large ones, we can reduce their sizes. Thank you so much for your patient listening. Thank you so much.